Hey everyone, and welcome back to the channel. Today, we're diving deep into a classic, high-yield pediatric case that you'll definitely see on your exams and in the clinic. Let's get started. We have a 2-day-old, full-term male baby in the nursery who hasn't passed his first stool, the meconium, since birth. His mom is worried. She says he's had one episode of green bilious vomiting. He's fussy, and he isn't feeding well. When we examine him, his belly is noticeably swollen and distended, and he's breathing a little faster than normal. Now, here comes the key physical exam finding. We perform a digital rectal exam. The anal sphincter feels unusually tight. But as soon as we withdraw our finger, there's a sudden, explosive release of gas and foul-smelling stool. This is the classic squirt sign or blast sign. This finding, combined with the failure to pass meconium, should immediately make you think of one specific diagnosis. To confirm our suspicions, we order an abdominal X-ray. The image shows multiple dilated loops of bowel, but curiously, there's no air in the rectum. This suggests a blockage somewhere down low. The next logical step is a contrast enema. The enema reveals a very specific pattern, a funnel-shaped transition zone in the rectal sigmoid area. The bowel above this zone is wide and dilated, while the segment below it is narrow. So, what's the most likely diagnosis here? If you're thinking Hirschsprung disease, you are absolutely correct. Specifically, this is the short segment type, affecting the rectosigmoid colon, which is the most common form. Let's break down the pathophysiology, because understanding the why is crucial. Hirschsprung disease is fundamentally a developmental problem. During fetal development, special cells called neural crest cells are supposed to migrate all the way down the gastrointestinal tract. These cells form the nerve networks, the Meissner and Auerbach plexuses, that controlled the coordinated muscle contractions of the gut, known as peristalsis. In Hirschsprung's, these cells fail to complete their journey. They stop short, leaving a segment of the distal bowel, most often the rectum and sigmoid colon. Without these crucial ganglion cells, without the nerve cells that signal for relaxation, this aganglionic segment remains in a state of constant contraction. It can't relax to let stool pass through. This creates a functional obstruction. Stool and gas build up in the healthy, innervated bowel just before the tight segment, causing it to dilate massively. This explains the abdominal distension and the bilious vomiting. The squirt sign happens because when you manually dilate the spastic segment with a finger or a rectal tube, the pent-up pressure from above is suddenly released, causing that explosive expulsion of contents. The failure to pass meconium within the first 24 to 48 hours of life is the single most important clue for Hirschsprung disease. It's seen in over 90% of cases. So, anytime you see a newborn who hasn't pooped, Hirschsprung should be at the top of your differential diagnosis list. While the contrast enema is an excellent initial imaging test to visualize that transition zone, the gold standard for diagnosis is a rectal suction biopsy. This is where we take a small sample of the rectal wall tissue. Under the microscope, a pathologist will look for the absence of ganglion cells. They'll also often see hypertrophic or thickened nerve trunks, which is another characteristic feature. Special stains, like calretin and immunohistochemistry, can make it even easier to confirm the absence of these ganglion cells. So, what are the next steps in management? The immediate priority is to stabilize the baby. This means making them NPO nothing by mouth to rest the bowel. We start intravenous fluids to correct any dehydration and electrolyte imbalances. We also place an esogastric or NG tube to decompress the stomach and bowel, which helps relieve the distension and vomiting. If there are any signs of infection, like fever or a very sick-looking baby, we'll start broad-spectral antibiotics. The definitive treatment for Hirschsprung disease is surgery. The goal of the surgery is to remove the aganglionic segment of the bowel and then connect the healthy, ganglion-containing bowel down to the anus. This is called a pull-through procedure. There are several different techniques named after the surgeons who developed them, like the Swinson-Suave or Duyamo procedures. In a stable neonate like our patient, this can often be done in a single operation. In sicker infants, or those with very long segment disease, it might be done in stages, sometimes involving a temporary ostomy. It's critical to diagnose and treat this condition promptly because of a life-threatening complication: Hirschsprung-associated enterocolitis, or HAEC. This is a severe inflammation and infection of the colon, which can lead to fever, foul smelling, explosive diarrhea, sepsis, and even death. The risk of HAEC is high if the diagnosis is delayed, which is why early recognition is so important. Finally, let's quickly touch on a few important differential diagnoses, the things that might look similar but are different. First, meconium ileus. This also presents with failure to pass meconium and abdominal distension. However, meconium ileus is almost always associated with cystic fibrosis. On a contrast enema, you'd typically see a microcolon, a very small, unused colon, because the thick, sticky meconium is plugging up the small intestine, specifically the terminal ileum. Another differential is intestinal atresia, where a part of the bowel didn't form correctly, creating a physical blockage. Depending on the location, you might see a double bubble sign on X-ray for duodenal atresia, or a triple bubble for jejunal atresia. Lastly, you might consider malrotation with midgut volvulus. This is a surgical emergency that also presents with bilious vomiting. The definitive test here is an upper GI series, which would show a characteristic corkscrew appearance of the duodenum. So, to recap, the key takeaways for Hirschsprung disease. Remember the failure to pass meconium in the first 48 hours? Look for the combination of bilious, vomiting, abdominal distension, and the pathognomonic squirt sign. Understand that the problem is an absence of ganglion cells, leading to a functional obstruction. The contrast enema shows the transition zone, but the definitive diagnosis is made with a rectal biopsy. Treatment involves stabilizing the patient and then surgical resection of the aganglionic segment. I hope this case walkthrough was helpful for you. Understanding these classic presentations is key to acing your exams and being a great clinician. If you found this video useful, please give it a thumbs up and hit that subscribe button for more high-yield content. Thanks for watching, and I'll see you in the next video.